Welcome to Mom Breaks. In this episode, we speak with Dr. Catherine Birndorf about postpartum psychosis, treatment, and the gaps in perinatal mental health care in the United States. Gaps she is addressing every day as a clinician and the founder and medical director of the Motherhood Center of New York. Dr. Birndorf is a reproductive psychiatrist whose work is grounded in direct patient care. She is building a state-of-the-art center that supports families experiencing perinatal mood and anxiety disorders, and they are looking to expand, which is exciting. She has contributed to public conversations about the emotional realities of new parenthood, including co-authoring the book What No One Tells You, A Guide to Your Emotions from Pregnancy to Motherhood, and consulting on media portrayals of PMADs, such as the Law & Order episode A Perfect Family, which depicts a case of undiagnosed postpartum psychosis. She also engages in current discussions around treating mood disorders during pregnancy, including the relative safety of SSRIs, despite a recent FDA panel where some stipulations recommendations led to confusion. Her primary focus remains on treating patients and expanding access to high-quality perinatal mental health care. Through her work at the Motherhood Center and beyond, Dr. Birndorf has become a leading voice in helping families understand that what's normal in motherhood is far broader and far more human than we often allow ourselves to believe. We also touch briefly on my own experience, medication, and outcomes, but we'll start with her own personal why and her journey to reproductive psychiatry. Welcome to Mom Breaks. We're so excited to have Dr. Birndorf on today. Welcome.
Thank you. I'm very excited to be here.
So first, would love to hear about what led you to found the Motherhood Center and focus your career on reproductive psychiatry.
Well, that is, I'm going to try and give you the short answer to a very long story.
Okay.
But I think my interest in women's health and just always empowering, promoting, and thinking about sort of where women fit in started long ago, with my upbringing of a frustrated feminist mother, and then going on to, Smith College and really figuring out what it was to have women represented everywhere. I really liked being at a all women's college. Just the learning of just really making sure women figure prominently everywhere, because somehow, and look at where we are today. I mean, I don't want to get all political, but let's just say
it's everywhere.
It's everywhere. And we are really, with the overruling of, the Dobbs decision and pulling back, 50 years of reproductive freedom, I felt like an invisible person. And I think I must, in my core, have always known that women needed to be supported and just, focused on very significantly to make sure that we get to exist equally in this paternalistic world where we're not driving. We're riding shotgun if we're lucky. And I think that's just sucks. So I want us to be driving. I want us to be informed. I want us to have everything to be, whoever we want to be. I mean, that's what I grew up with. Be whoever you want to be. That's what it felt like to go to an all women's college. Like I could do anything. I could be anything. Go get it done. So that's where it all started. And then when I ultimately found myself in med school, I won't tell you that whole story because I didn't go to college thinking I was going to do med school. I was going to do reproductive rights. And I was going to do policy and, but I ended up working in a halfway house and in an abortion clinic. And that defined the rest of my life, these 2 part-time jobs. I was like, this is it. And I went to med school thinking I'd be an OBGYN because I felt the calling to, if I could, I should provide these options for women if they needed to make the decision to terminate a pregnancy. So I come to it that way. And I decided to go psychiatry versus OBGYN because I didn't want to, I was like, it's fun to deliver babies, but like, I want to talk to the moms and I want to be a different part of this experience. And I don't want to stay up all night. I need my sleep to be productive, but I combined it I didn't even know it existed at the time, in psychiatry, I knew I could get there because I knew a few people in the field. They were the originators of this field of reproductive psychiatry, who I was like mind blown when I figured out I could marry my interests and my passions. And I was like, oh my God, this is what I'm going to do. I just wanted to get back to that point about empowering women to make choices. Like, that's what I ended up doing. I didn't do it through OBGYN and, termination services. Where I ended up doing it is through medication management, really helping women, because my academic specialty is really around helping women or birthing people make decisions about whether or not they should be on medications related to their psychiatric illness during the time of pregnancy and postpartum. Trying to conceive, being pregnant, or postpartum, when they are told they have no options. Like, for some people are like, go off your meds, you can't be on that. And then other people are like, yeah, I think it's fine. Yeah, go ahead. Right. And nobody wants those ends of the spectrum options. They want a nuanced, we have to be able to think about this thoughtfully and in a nuanced way, taking in the data, understanding it, and then working within the context of that patient's life. So for me, I kind of, as my dad, who said, why do you have to do high risk psychiatry like that? Like, you're medicating pregnant. I was like, geez. And my parents are so supportive. I just want to be clear. My mom was thrilled that I went to Smith, and my dad is thrilled. He's also a doctor, that I became a doctor, but he's like, he's an ophthalmologist, super safe, like straight, on the straight and narrow. And I'm like doing this like crazy kind of psychiatry where I'm medicating pregnant women. And he said, but what's the liability? And what are you doing over? I'm like, you're going to, oh no. I was like, Dad, I am helping people make decisions for themselves so that they can go forward in their lives, do what they need to do and want to do. And that's always been that's the theme of like what I want and what I want for everybody else.
I see the through line,
you see the through. I wanted to get the through line.
Feminism, supporting women, empowering them to make choices about their own bodies. I see it.
Thank you. I had that was a long story to tell. I could have just given you that through line. I'll work on that.
No, that was great. So talk to me more about the Motherhood Center and how that came to be.
Okay. So along this journey of figuring out myself and what I want to do and my passion and what feels much more like a career driven by mission than I ever knew, there were so many obstacles along the way to be able to keep pushing this ball further down the field. So
like within current systems.
Correct.
Say more.
Right. So here I am. I discover this field I want to be in that didn't really even have a name yet. This is the mid 90s. My mind is blown. I go visit some, Lee Cohen up at Harvard. I go visit Vivian Bird at UCLA. I go down to Emory to see Zach Stowe, and I learn about their programs, which were kind of, and I had, Laura Miller and Chicago. Like, there were these people in the field that just, they were doing it, and I wanted to be able to do it in New York. And there was Meg Spinelli was there, thank God, and she was so, and we adore Meg, but it was all siloed and it wasn't really happening, and to me. And so you kind of had to like seek out who's doing what. And I was at Cornell, at New York Press at Cornell, and they were like, we don't have any of that.
A quick note on the Dobbs decision and the names she just listed off. In the United States, the 2022 Dobbs decision overturned Roe v. Wade, which had protected a federal constitutional right to abortion for nearly 50 years. So the case was named after Thomas Dobbs, who is an infectious disease doctor who became Mississippi State Health Officer in 2018. He oversees the agency that inspects the Jackson Women's Health Organization, which was the state's longtime sole abortion provider. By reversing that precedent, the Supreme Court returned the authority to regulate abortion to individual states, which creates a patchwork of access. Some states have banned or severely restricted abortion, while others continue to provide broad access. Some pregnant people have had to continue unsafe or unwanted pregnancies. There's one research paper that I can link that examined rates of live births and also infant mortality across states, including 14 with early or total bans. They found that there were impacts, particularly among those already vulnerable populations. For example, they found that Black infants died at a rate 11% higher than what they would have expected without bans. And mortality increases were especially pronounced in southern states for those without a college degree, Medicaid beneficiaries, unmarried or younger people, and it generally just highlights pretty stark inequities in maternal and child health. On the physicians, many are involved with a women's center for their organization, often within a university system, which is great and can serve as hubs for connecting to therapy, medication management, and some have like weekly intensive day programs. There's Lee Cohen directs the Ammon Pinizotto Center for Women's Mental Health at Massachusetts General. He's a psychiatry professor at Harvard Medical School. Vivian Burt is out of UCLA. She led the Women's Life Center there and now practices adult and reproductive psychiatry, offering telepsychiatry care in Southern California. Zach Stowe is at University of Wisconsin-Madison, directs the women's mental health program there, and studies perinatal treatment and has a focus on epilepsy in pregnancy and medication exposures. Laura Miller is at University of Illinois Chicago, has affiliations with Loyola, and has developed women's mental health services and policy initiatives and education around mental health care in the postpartum period. Meg Spinelli is based out of Columbia University. She is a professor and a researcher. She founded Columbia's women's program in psychiatry, focusing on perinatal mental illness, education, and advocacy. So while these centers are providing support, which we need more of, Dr. Birndorf is offering a distinct partial hospitalization structure with daily touch points, bridging the gap between outpatient therapy and inpatient care for families experiencing perinatal mood and anxiety disorders. So let's get back to that.
And I would go see, I was like, wait. I thought I was coming here and it was going to be New York. I was going to have all these opportunities, and you told me you had all these women. And so I was from the beginning sort of like, oh no, they don't have what I want to do, but I want to be here. And so I just kind of like,
You were like advocating for yourself within trying to advocate for women.
that's how it started. And by the way, I'm still there because the Motherhood Center is now, I don't know, this is 25 years later. I'm still sitting in a position. I must really like to be a fighter, rebel rouser who's like always pushing the envelope, because we are still trying to get insurance companies to acknowledge that the idea of having a perinatal partial hospital program where women can be with their babies, because we have a nursery on site, and that perinatal illness based, in this attachment kind of treatment center is worthwhile. Not just worthwhile, saves them money, because that's really all they care about.
Right.
We keep the patients out of the hospital, we keep families together, we mitigate illness going forward, we help with the epigenetics of lines of illness and future from the past and into the future. It's almost like a no-brainer, and I can't tell you the amount of pushback. It's really hard to have the Motherhood Center just be a thing that insurance will pay for and that the world can acknowledge.
So they like want it to be acute hospitalization in order to legitimize it? Like insurance companies? Like what are they?
Yeah, they're like, what do you mean? Just a partial hospital, like any other partial where adults go. I'm like, no, well, we actually have two patients. We've got the baby, we've got the mom. It's, again, we're not even thinking about charging for the baby. It's like the mom has a complex family system that is based on a dyad. If they're pregnant, it's the pregnancy. If the baby's born, it's the baby and the mom and the greater family. We address all of that within this. We have the nursery on site so people, stay with the baby because they might have been separated in the hospital.
Right.
They basically are like, yes, so what? big deal. That's the same as just a partial hospital. I'm like, oh my God. So it's like trying to
Oh.
convince the payers that this is something that matters and makes an enormous difference in their bottom line and in the lives of families.
So is that true for, because I know there are a variety of outpatient mother baby places within the US. Is that an issue like around the nation?
Well, there are a variety. They are mostly hospital based. So they are
Oh.
within the context of
Ah.
a hospital so that they are under that umbrella. Their licensing comes from the bigger system. They are, there aren't many. You really have to have a champion who wants this. You have
Yeah.
to have right. And then you know you're going to be a money loser for the hospital. So you really, they have to, it's all about, it's always
Oh.
within that economic structure. So I wanted to do it outside of a hospital. We are freestanding and agnostic, meaning, even though I'm very affiliated at Cornell, we're outside the system so that all the other hospitals and doctors
Can
and mental health professionals and doulas could refer to us. And that's what I think we should be. The Center is, our mission is about providing, we educate, we diagnose, and we treat women with perinatal mood and anxiety disorders. That's what we do. And so that they can be well and go on their lives. And so we're doing it in this particular way with our day program slash perinatal partial hospital. And to me, it is just one of the most no-brainer things to do between standard outpatient treatment and inpatient treatment. There is this abyss between those two where women need more support and care. And because it's not, an operation or an interventional service where there's reimbursement, it's not something a lot of people want to do or have because it just
Mhm.
doesn't pay for itself really. So we're trying
Oh.
to find creative ways to do this outside of the bigger system. I was again, I kind of got stopped. Like I pushed as far as I could at Cornell to create. I started the program there in 2002. I finished residency in the late 90s, went to Chicago, did some apprenticing, learning, came back, started this program, but I kept pushing. I wanted to do, okay, now we got it. It's in the residency program. People are learning it. Then I was like, okay, we'll get a fellow. Great. We had our first fellow. Then I was like, now I want, like, we considered a partial hospital program. And at the last minute, they're like,
Oh.
we're going to go adolescent, not women.
Oh.
I was like, I guess it's probably time for me to go. Like, I got to go
Oh.
find somewhere, right? Like, so 10 years later, then,
Mm.
actually, it wasn't even 10, probably 8 years later was when I started this process with lots of people's help to begin to open up what I wanted to do that I couldn't do there, like on my own
Within a
in a different,
system. I'm curious about if you set a precedent here, do you see a future where you could scale it
oh,
to
that's the goal.
many? Okay.
That's the goal.
So we're kind of talking about some systemic barriers. So insurance systems, also just the way of structuring care
The,
within a hospital system versus
the
a
medical
private.
establishment.
Yeah. What else do you think it would take to make these programs more available throughout the
Well,
nation?
our goal, the vision at the Motherhood Center really is we have been crafting this kind of pilot program where we're kind of like a mini hospital ourselves, but we've been working very hard over these almost 9 years to create something that is um, state of the art in terms of the care that's being given, that can be, a model to take forward everywhere, right?
Mm,
And I don't think it may work within a hospital system, but I haven't seen it happen. Like, I mean, there's some wonderful programs. There's a handful, but that's about it. And then there are more recently, there, are some different kinds of programs, but I'll stick with what we do. Like, and so my goal is to create this, and we can't do it without partnering with insurance companies because
yeah.
or finding a way to to make it accessible to all. Right now, everything's a one-off. So it's really hard to
Oh,
run this business. I can come back to that. But our goal, really the obstacle right now is like licensing an insurance company. So we keep doing every day. We always say to each other, whenever it's a bad day, it's like every day we save lives. We're doing the work. We're doing the work that we need to be doing. But it needs
yeah.
to be for everyone. We've treated over 1,000 patients in our day program in these,
Hmm.
but like we need to be treating, there's so many more people who need this care. So we are about to open in New Jersey. So we are about to have our second
Oh,
center.
congratulations. That's
Thank
amazing.
you. I won't accept the congratulations until I have the
Oh,
email that says you've been approved, which has been a 2.5 year process, which required going up to the governor because we had to, and hiring a lobbyist. I cannot tell you how hard it was to,
whoa.
we did this in New York too, but it was maybe even harder in Jersey to really, because if you don't have a license, you aren't recognized by the insurance companies for what you do to be able to have
Oh,
the care that you give be covered. So
yeah.
even if you're not in network with the insurance company, you won't be recognized them so that the patient gets reimbursement. So it's a very complex matrix, and it's huge that we're just getting ready with our where we're going to hopefully be in Bergen County. We're going to hopefully be around Paramus is our goal, and open our second center, and replicate what we've done in New York there. And we're talking to some
Mm,
people in Connecticut about different ways of partnering. Like, so we have different ideas, but really we should be in every big city, not just
mm,
my goal every state, right? But like, because
yeah.
it's just like it's kind of no brainer care, which I haven't even talked about what the care is, so we can come to
I
that.
know.
But the obstacles to having getting it done are just they're
Yeah.
never ending.
Do you foresee doing more New York locations?
I'd love to, but I think we'll go. We're New York State now, so we can have people hybrid in from Albany or from
Oh,
the Finger Lakes. They can also come to New York City because we have a New York State license. So
okay.
we're licensed by the Office of Mental Health, and we can treat anyone in the state of New York who is appropriate for our care. And we can figure it out with their insurance company, which we do. We
Oh,
work with all the insurance companies, including some Medicaids, but mostly it's commercial insurance to figure out how to get someone paid for to get our services. And each one is its own individual delight, otherwise known
that
as a
sounds like
nightmare.
legwork.
Right?
Yeah.
Right? But we have a huge team that is just like, we're going to claw our way to figuring out how to do it.
Oh,
But it needs to
wow.
just be easier. I mean, what makes it not scalable? Because we have to be able to,
Right.
this has to be much easier to do.
Well, custom pricing per patient and doing each insurance
Well,
reimbursement, that
it's not
sounds like
custom pricing. It's the insurance companies. It's figuring out with them what they will pay, what they can cover, what the patient can contribute to that or not.
okay.
It's its
Yeah.
own alchemy of hell, trying to figure out like how to do it. And so would
Right.
I love this to be much more accessible? Yes. At the moment, we can get most commercial insurances to pay the big bulk of treatment because treatment's
Okay.
about 8 weeks long. It's like average length of stay at the Motherhood Center is 7 weeks. And some people are there for 4 weeks and some people are there for 14 weeks or more.
How does treatment differ depending on what the woman's going through? Like 8 weeks, 4 weeks,
It's
what's the difference?
Well, some of it has to do with how long someone can stay, right? In terms
Oh,
of, right, like if they are on maternity leave, have to go back to work, if there are other, pressures financially or, whatever the issues are. So
yeah.
we take anyone who's experiencing a PMAT, again, that meets criteria that, if someone is, unable to be safe, even earlier this week, we had to help someone get to the hospital because they had come from the hospital and they probably weren't entirely ready to be out of an inpatient unit. But we were able to
Oh,
have her be with the baby, but she has postpartum psychosis, and we were
oh,
trying to manage her in our outpatient setting. And that's our highest level, most acute patient when they're stepping down from the
uh-huh.
hospital and they are coming to us. They're not in the hospital that long. Thankfully they're on their, lithium and olanzapine, a terrific cocktail for kind of new onset postpartum psychosis. And then we take it from there after about a week in the hospital often, or maybe a couple weeks. And not everybody's ready to be out of the hospital. So this particular person,
Yeah.
we had to unfortunately re-hospitalize. But that's rarely the case. Mostly people come, we can manage very high acuity cases as long as the risk of hurting oneself or one's baby is not, that we can manage that
Right.
risk outside of a hospital. But we also have people who are stepping up from outpatient who just like are calling their professionals all the time because they're just not making it an outpatient. Like once a week or one group or three touch points a week just isn't enough. They need
Oh,
to be
more.
more, to have community, to have, this group-based treatment where we're using all different modalities, learn to have, we do a very big DBT kind of strata or path where people are learning the skills, and we have a dyadic, we teach a lot of things. So that you gain so much from it that I think it should be for everyone. Skip the illness. It should be for every new mom, I guess.
Yeah.
But I might
Built-in
be,
community, education, therapy. Yeah.
and learning how to be a parent. Right? It's the transition to
Yeah.
motherhood. It should be for everybody. But at this point, we can only get you covered if you have an illness that we can.
Yeah.
Yeah.
Yeah. Can you say more on what differentiates the approach at the Motherhood Center from like these outpatient programs you're referencing?
Yeah. It's holistic, it's wraparound, it is integrated. We have all different specialties. So we're based really, I mean, these are medical illnesses. We have
Hmm.
many reproductive psychiatrists. All of our therapists are, everyone at the Motherhood Center is a specialist or a
Specialized.
trainee or a trainee. We train postdocs, so psychologists. We train psychiatrists in reproductive psychiatry. We have had social work training. We're going to get that built up again. We have had nurse practitioner training. We have one happening now. So we have multiple different disciplines, but the centerpiece, everything is perinatal. So there's
Hmm.
nothing, we don't treat the full range of reproductive psychiatry, menses to menopause. We only do trying to conceive, fertility, loss,
Hmm.
miscarriage, grief, and then conception, preconception counseling, like what meds should I be on? Or I have a history of this, I'm on that. Does that work? Then
Hmm.
pregnant, everything related to the therapies around and the medications around the pregnancy piece, and then the postpartum. And a lot of the work is in the postpartum, around breastfeeding or not. It's just feeding, taking care of oneself, integrating, this new identity and all of that work. And so that we have a very narrow spectrum of who we treat. And within that, we have these multidisciplinary, we have people coming from all different kinds of lenses, but all around the patient at the center who's in this period of their life. And we work out individual treatment plans for each person.
Yeah. I would love to get more of your clinical wisdom on PMADs. So, and particularly, yeah, so postpartum psychosis is sort of the focus, but so many, like these moms are dealing with usually many disorders. I was reading one paper that talked about anxiety and depression almost being like stepping stones. That was interesting.
Stepping stones? What do you mean stepping stones?
I can pull the like statistics that they ran. I
Well,
don't know off the top of my head.
because I guess to me that sounds like those can lead to something else, when I would say that those are
Distinct.
they are often their own thing. Or I often describe anxiety and depression as like soul sisters because they can be very, very related.
Yeah.
But I don't know that anybody who has those is then moving on to, I mean, postpartum psychosis is very distinct from postpartum anxiety, postpartum depression, postpartum OCD, or perinatal, actually, sorry, because
Uh-huh.
these can occur. They can be start during
Okay.
pregnancy.
Like comorbidity
There's a lot of
more.
comorbidity, right?
All right, that study I was thinking about, I had read shortly before this interview. It was published in 2024. It's called Relationship Between Childhood Trauma and Postpartum Psychotic Experiences, the Role of Postnatal Anxiety and Depression as Mediators. So it's a bit more niche than I was remembering. They're looking specifically at childhood trauma, and they look at just over 400 postpartum women and found that childhood trauma, particularly psychological abuse, is strongly associated with postpartum psychotic experiences, and that postnatal depression and anxiety were found as key mediators of this relationship. So they sort of spotlight how there's long-term impacts of early trauma and recommend targeting and addressing childhood trauma through therapies as well as depression and anxiety symptoms, and perhaps that could help reduce psychotic experiences. That's the phrase they use in this study. So anyway, yes, I love the note that anxiety and depression are distinct from psychosis, though they can co-occur. Also wanted to include, I wasn't that familiar with DBT. It stands for dialectical behavioral therapy. It's a structured, skills-based form of cognitive behavioral therapy. It's designed for people who experience emotions intensely. It gives you practical tools to manage emotions, tolerate distress, and improve relationships. It looks like it was developed originally for those with chronic suicidality or borderline personality disorder, but it's used widely now for many emotional and behavioral challenges. The dialectical part refers to holding two seemingly opposite truths at the same time. So acceptance, validating your experience, and change, learning new skills to reduce your suffering. DBT rests on this idea that you're doing the best you can and you can learn to do better. So if you were curious about that, there's a little summary.
So then how would you define psychosis, postpartum psychosis, and how
As
is it
different from all
distinct?
these other things. Postpartum psychosis is an illness. It is probably our biggest emergency, potential emergency, kind of urgent. We must treat this illness because there is a big safety risk. So when someone is not in touch with reality, right? Psychosis is essentially the break from reality. Then we don't know what could happen. It's like a mom not being in her right mind. So the way I say it is, because these things get sensationalized, horribly, horribly tragic
Yeah.
things happen with someone who kills their child or kills themselves. I always say any mother in their right mind wouldn't do that, couldn't do that, right? Like that's just not the mind of a well mother.
Yeah.
You may have thoughts about it. You may be overwhelmed. You may have fantasies. But when someone has a psychotic illness, they can't discern between what's real and what's not.
Reality.
Okay, so that distinguishes it, and that's what makes it an emergency. So it's really important that someone who is not acting like themselves, who is not making sense, who seems confused, who isn't sleeping, is not able to care for themselves in the way that they could and used to, who is feeling paranoid, who might be thinking that strange things are happening and messages are coming from elsewhere, or certain movements in the world are happening very deliberately, right? So I'm describing delusions, I'm describing hallucinations, paranoia, right? Those are, more technical terms for some of these descriptors that people will give. And it's like, let's go. We got Houston, we have a problem and we got to get in there immediately. So,
Yeah.
but it can be very subtle. It can be subtle. It can be, it's an illness that waxes and wanes. So, someone may be very reality based about lots of things and then not reality based about others. Or certain times of the day or certain moments of the day, they're really with it and seem fine. And at other times, that's not what's happening in that person's mind. So it's not that easy to recognize always and to treat because it's just, let me start by saying it is so treatable. We get people better. We make sure they're safe. We get people better and they do so well in the world. Like it's not even a question. Like these illnesses are so treatable as long as they really are.
Get treatment.
As long as you get treatment. And it can take a year, right? Like it can take from first, the onset of a symptom to really figuring out what's going on, getting a diagnosis, getting the treatment, figuring out how to manage that. Then there's the getting well. Then there's the integration of what the hell happened to me.
Yeah.
Who am
Grieving.
I now? Right? And then there's like, can I go back? Like, who am I now? And what does this mean for the
Uh-huh.
future? Like, that's a long process, but it is absolutely doable. And it's not, I don't say this lightly, but it's super treatable. Like if we can get it, we know what to do.
Yeah. Yeah. Can you say more on what the gold standard for treatment is? You mentioned lithium and I'm not going to be able to pronounce the other
An
one.
antipsychotic. What did I say? I don't know what I said, but
Laraxis,
olanzapine.
olanzapine, that was it.
Yeah, that's one of the second generation antipsychotics, but it doesn't have to be even that specific. It's a mood stabilizer and a antipsychotic.
And
And if we, because these often are presumed to be bipolar illness showing its
hmm
coming out for the first time, early in the postpartum. And when someone gets hospitalized, those are typically the things we suggest because we get called and they say, we'd like to, we have a patient we'd like to refer to you. And we listen to what they're on and we say, hey, why don't you consider starting this and let's get them, let's get those meds on board. And then we'd love to be able to treat them at that next step. But without that, is
Mm,
so the rate of relapse without good enough medical and medicinal intervention is pretty
mm.
darn high.
You make sure that there is a mood stabilizer and an antipsychotic upon
Typically.
discharge.
To me, that's the
Okay.
goal. That's not
Okay.
always what happens. We don't not take someone because that didn't happen. We
Yeah.
try to help make that happen. But people come to us. They've been in the community. Like, let's say they are discharged from the hospital. They don't know about us, or they didn't. They get outpatient treatment, and someone's like, "Oh, you seem depressed. Let's add in some, an antidepressant." Like all kinds of things can happen with the medication piece. It's nice when we can help from the beginning to try and say, here's what we've seen over these many years. And, at one time in our program, not a couple of months ago, we had 7 women with postpartum psychosis at once.
Wow.
And we can have 26 people total in 2 different cohorts. We had 7 women, all who had or were at some stage of in recovery from
Recovering.
postpartum psychosis.
Did you see any sort of trends in the COVID era?
That's a great question. I think it was, in some ways it was easier, in some ways it was harder because more people could, we went fully on screen, right? So we went virtual. So, and we could see families. I remember the first patient who I
Oh,
was evaluating who was psychotic and the partner was right there. And I sort of said like, I could see what was, I said, oh, is this how your, partner usually is? And they were like, well, not really. And the partner was like, what are you talking? Like it was just a very
like, yeah.
interesting. It was like not that I wouldn't want to have that also in my office, but we were zooming into people's homes in this really unique way.
hmm
So I don't know. It really, I don't know if I fully processed what was so. It was fascinating, but yeah, I do
Yeah.
think people didn't come to treatment as people were
Yeah.
scared. We were all scared from this epidemic that
It was
we didn't know what was going to happen to us.
it was a weird time. Yeah.
Yeah, and illness, PMADs skyrocketed. So yes, I think there was
Mm.
more of everything, the stress, the pressures, the lack of care, the
Yeah.
isolation.
Fewer treatment or less ability to access care, but like increased stress
Yeah,
potentially.
yes. Yeah.
Okay. You mentioned bipolar and postpartum psychosis being linked. Can you talk more about the relationship there?
Yeah. I think that at least when I was, you know, 30 years ago when I was starting to train, I think both postpartum psychosis was really considered to be bipolar until proven otherwise. Right? Like that was somebody who
Oh,
had not previously evidenced a or had not come to care, had not come to treatment, but there
huh.
were antecedents, maybe there weren't,
Uh-huh.
or there were family members that were known to have it, but it first showed up in the postpartum.
After a baby. Oh.
Correct. And that's when that's, as we say, the index episode of either mania or psychosis occurred, or maybe it was a suicide attempt, right? Like you'd see that. And when it happens
Oh.
early on within the first week, 2 weeks, first month, immediately I'm thinking, well, let's see the symptoms here, but we probably have a postpartum psychosis. And where's the bipolar in the background? Was there ever, let's look for it in their history, in the family history, everywhere. And what's super interesting and this is where Verily Bergink, who you should definitely speak to, she kind of, and I had been seeing this in my practice, and we see it at the Motherhood Center, but she really sort of defined what's kind of like, she calls it an orphan illness, but I don't know. It's like, it's just postpartum psychosis, which I think is a variant. We do think is probably a variant of bipolar illness, but I've had several patients who only got sick postpartum, treated for 6 months, could come off their medication. Initially, I was treating people for a year, and I was begging them not to come off meds because I'm like, you have bipolar illness,
Yeah.
don't come off. You're going to get sick. Through many trials and errors, and people saying to me, Dr. Birndorf, I'm going off my meds. I'm sorry. And I'd be like, okay, let's watch you really closely, whatever it was. So I went through a lot of that with a lot of patients over many years, but
Yeah.
it really turns, so I don't know that we have an absolute standard of care for how to treat this, but what you do find is people can be quite well without bipolar appearing illness in between episodes that only occur postpartum.
Mm-hmm. How can you distinguish between mania that's part of like bipolar or postpartum psychosis versus psychosis that is something else?
That's a long question, or it's a long
Okay.
answer to it. It's more just, I guess what I'd say is you want to just find out what is someone experiencing? And then you're on, sort of in a detective kind of way, trying to put together diagnostically what you think the differential is. So what do you think? You put together all these pieces. And again, it includes their current state, their past, mental health, family history, and kind of what they're expressing in the current context. And then you create a differential diagnosis list of like your top, what you think it could be is this. It could also be this. You have to rule out that. You have to rule out. So you might, like when you're trying to distinguish, what you're really doing is trying to figure out, given that symptom, the most prominent symptom and the other things that go with it, what could it be? And therefore then how do we treat it? But sometimes it's like you see the symptoms, like you had psychotic symptoms and they treated your psychotic symptoms.
It's kind of necessary.
Right.
Immediately.
What?
I was just making a lot of commotions in the ER. Like they needed to.
Right. But you could say, was that mania? Was that psychotic? Like that could have been a lot of things. Like lack of sleep could have been one of the precipitating factors in addition to other things. But again, most people with lack of sleep aren't going to evidence illness and symptoms like you did, right? So something's there. The question you're asking kind of is what is it, or what was it?
As this last clip shows, Dr. Birndorf was gracious enough to spend time talking about my experience. The clinician in her is strong, and she asked really thoughtful questions. And I've pulled some of that conversation out, and we'll share more in an upcoming personal reflections episode. For now, here's a short clip of her responding to one speculation I had about what might have contributed to my psychosis.
Lots of things can trip a wire, but that doesn't mean they caused it. They might be the stressor that pushed you over the edge. That doesn't mean that if I had the same stress, or if you and I were both in the exact same situation, that I would have then gotten psychotic. Do you see what I'm saying? So
right. Yeah.
And that brings us to the end of today's episode with Dr. Catherine Birndorf. So grateful to her. It was really helpful to get her input on many of these questions, and loved that I got to talk a little bit about my experience, which again, I'll share a little bit more in an episode in the future. We covered quite a bit from the practical and systemic challenges of building a partial hospitalization program in the United States. We talked about insurance and legal hurdles that come with it, and the personal mission that drives her work. She spoke about advocating for women, helping them make informed choices about their bodies, and creating support for them in a world that can be quite paternalistic. We also explored how postpartum psychosis presents, its relationship to bipolar, and the treatment approaches clinicians rely on when time and safety are critical. There is more to learn. She mentioned Dr. Verily Bergink, who is a leading researcher on postpartum psychosis, and that conversation will come out soon. We'll dive deeper into what the research tells us, what we still don't know, and how the field is evolving. Thanks for listening, and huge thank you to Dr. Birndorf. See you next time.